Hello and greetings to everyone present. I'm glad to be a part of such an important series, and we have already come to the fourth session of the series, which is the territorial dimension of care services, which is which is of the utmost importance for us in the local and regional governments. In South Asia, as we see, and in most of the other parts of the world, community health workers, who are known as ASHAs, Anganwadi workers, lady health workers, and female community health volunteers in the region of South Asia, are a large section of the health workforce, which is comprising mostly of women. They are the first point of contact between the communities and the public healthcare system in our region. These are actually the grassroots crusaders who are providing medical services in the most remote places where, as of now, as yet, medical services have not reached, and amongst their communities. The community health workers are appointed from the communities, and therefore they are overwhelmingly women. Here I would like to share a table that shows a comparison. We see is that most of the workers are paid as minimum as in, especially in India and in Nepal, as minimum as yearly 500 US dollars, 250 to 500 US dollars. It is a workforce comprising of a minimum of 50,000, 50 to 55,000 workers in Nepal, whereas in India it is almost 1.2 million ASHA workers and other auxiliary workers are required. So what the main tasks are: family planning, institutional delivery, child health, health education, and child education. And also they help in family planning, safe motherhood, and immunization. While we also see is that in the countries in South Asia, they receive the minimal training of 18 days to 3 months, 3 months being the highest in Pakistan. So, and there is no ongoing process of any additional trainings that they are provided in their jobs. And with that, while they are expected to do this vital work without being recognized as public healthcare workers and without wages. They actually work as volunteers, but except in the case of Pakistan, where they have won recognition as public healthcare workers in the year 2018. Well, it is important to mention here that the union in Pakistan fought for more than a decade in achieving recognition and winning regularization as public sector workers. And it is very vital to mention is that while in Nepal and India, we have as meager as 250 US dollars being paid as wages. In Pakistan, and minimum wage is being paid and as high as 2,250 US dollars, along with other social security benefits are being paid to same section of the workforce. Well, if we see this characterization of community health workers as community volunteers and activists, it actually reflects the historical and continued devaluation of women's work, as Daria had also mentioned previously, which is actually a widespread trend in low-income countries. It actually also signals the government's unwillingness to invest in regular cadre of human resources for public health in rural areas, especially this section of the workforce is catering in to the rural areas and some parts of the urban areas, as it would have a long-term fiscal implications, while where they are able to get this workforce in such a low wage and being able to exploit their labor day in and day out. So, at this point, highlighting COVID-19 is very important, because during COVID-19, a number of researchers have shown that with the additional pandemic duties, ASHA workers across India have been working on an average of 8 to 14 hours a day in field, including the weekends. While when a ASHA worker is employed by the government, by the state or the central government or the local municipalities, it is said that they are volunteers and they are required to spend 7 to 8 hours of in a week of work is required to be done by them. While we are also seeing higher number of community health workers being roped into the vaccination awareness drive without while without any additional incentives being paid for this work. What we have also heard and seen across the region is that the community health workers, whenever there is a new scheme coming up or a drive that the government is launching, they are the first section of the workforce that are taken into for doing the work, but no additional incentives are ever provided to them. So here I would like to highlight the central point that is that although the workers are providing a very important public healthcare service under the schemes of the central and the state governments and local municipalities, governments are continuously failing to recognize them as workers, while simultaneously what we have seen during COVID-19 is that they're formalizing community-based interventions, especially for containment of COVID-19 in countries like India and Nepal. While they're working as volunteers, they're not entitled to a minimum wage or social security protection. While in Pakistan, they're entitled to a minimum wage, social security protection, and other benefits. Thus, we have to mention here that in that this section of the workforce, although is indispensable for the public healthcare system and they form the backbone of the system, they remain the most overworked, overburdened, and underpaid workforce. While I have been mentioning some of the challenges that we have been seeing with the workforce, through our project work, we are engaging with our affiliate unions who are working relentlessly in organizing the section of the health workforce, especially in the 3 countries in South Asia, which is India, Nepal, and Pakistan. Although there is this section of the workforce is also working in countries like Philippines and the African continent, where PSI is also engaging and trying to organize the workers. COVID-19 has actually emphasized the critical importance of public healthcare workers. While we have seen people coming out and clapping and showering flowers to them, but what we have not seen is remunerating them for the work that they are doing. We actually saw COVID-19 as an opportunity for highlighting the community health workers' work in South Asia through a regional campaign that was launched in late 2020, and it is an ongoing campaign for the recognition of the community health workers' work. And we go with the tagline of actually recognize community health workers, and community health work is work. And we are trying to, through this campaign, we are actually trying to highlight and demand for decent work, because decent work provides a very crucial momentum to ensure protection to these workers, as well as also guaranteeing the quality of services that they are providing. We are also actually engaging with international organizations like the International Labour Organization and the World Health Organization in highlighting the issues of community health workers. Actually, WHO has also come up with several guidelines for the community health workers, but implementation on ground is yet to see the light of the day. When the ILO General Survey for the Nursing Convention of 149 and recommendation of 157 was conducted, PSI, on behalf of PSI and the affiliate unions from all across South of Africa, South Asia, and Philippines, we made a community health workers specific submission in the general survey, and we were also able to actually have a face-to-face presentation, online presentation with the members of the ILO who are heading the survey. So finally concluding, we are actually working in adherence to the 5 R's of recognizing, rewarding, reducing, redistributing, and actually reclaiming the public character of care services, which will also be highlighted later, for rebuilding the social organization of care in the region. Well, I would like to conclude, but would actually like to end with the most important demand on behalf of the community health workers in South Asia, is that recognize our work and regularize us as public sector government workers. And with that, I would like to wrap my part and would be happy to take up questions. Thank you so much.